First, Dr. Pawan Kumar. He's the Additional Commissioner for Maternal Health at the Ministry of Health and Family Welfare. We're also joined by Poonam Mutreja. She's the Executive Director of the Population Foundation of India. Good morning. Thank you so much for joining us right here on the show. Okay, let's just go very quickly. Dr. Kumar, we'll come to you first. Doctor, take us back. First, give us a timeline. Take us back to when India stood higher in the numbers. So we were telling our audiences, years ago we were at a 500. Now, just a few years ago we were at 100. Now we've come down even further. Tell our audiences back to that time. How many years ago was it when the numbers weren't so good? Take us back to that time. Tell us what the situation was across the country in different pockets.
Yeah, thank you. Good morning, everyone, on all the audience. Because we are discussing a very important topic today, that is a maternal mortality ratio. And if we go back 2 to 3 decades back, when the MMR of the country was around 500 plus in 90s, and which has incremental progress has taken place, and now which is standing at 97 as per SRS data of 2018 and 20. So we are standing at 97. And the progress, if we see in the global data, the global MMR was in 90s around 385, and which is standing as 223 as of now. So if we see the fall in the MMR, it is 42% in the global. But if we see in the Indian context, the fall is much more steeper, that is 83%. Yeah. This means lot progress has been made. And if we see in 2014, the MMR was 130, and now which is standing 97. And we have a SDG goal to achieve at 70 maternal mortality ratio per 1 lakh live births by 2030. So what I want to convey is that the trajectory which the MMR is falling for the country, and we are pretty confident that we'll be able to achieve our SDG goal before 2030.
I see. Interesting. Poonam Mutreja is also with us. Ma'am, the beauty of this number and why it stands out even more is the fact that post-pandemic, we saw a lot of our metrics take a hit. A lot of programs had to be put on a pause. Overall, globally, we've seen a push back on women welfare. But this number still shines out. Could you take us through what has contributed to this?
So, good morning, and it's wonderful to be talking about women, because it's not just about women's maternal mortality. It is about the care we are giving to the women of India and a commitment to women. So what are the reasons for this huge progress? I would say first, primary credit goes to the Ministry of Health and Family Welfare in India that started the National Rural Health Mission in 2005, and we saw huge decline since then because maternal mortality was given priority. It was given political priority, and I would say that the bureaucracy in India, across India, but I must say, as I worked with the ministry that time very closely, having started working on maternal health in the 90s, which Dr. Pawan referred to, that's the time that all these investments were made, whether it was institutional deliveries, bringing women into institutions, especially those women who had a risk. We never did a risk assessment before. When we started doing the risk assessment, and women with high risk were taken care of all through the process. Second, the Pradhan Mantri Suraksha Matre Abhiyan, which has contributed significantly, along with Janani Suraksha Yojana. Janani Suraksha Yojana of the government is the one that pushed and encouraged, and I mean pushed in a very nice way, institution deliveries where women came and delivered in institutions. It was a huge increase, and for the public health system to cope with the huge increase, of course, this was done with the help of ASHAs and ANMs. And finally, Lakshya, which you mentioned too, for quality maternal care, further contributed to the decline. This is a scheme which I really welcome, because quality was a big issue, and the government and NGOs worked together on testing the Lakshya scheme and bringing it into the system. But I want to say, since you talked about COVID, I want to say that during COVID, the Ashas and ANMs who were our heroines, you know, there are films on Ashas as COVID heroes, they ensured that they did their best to ensure antenatal, postnatal care, as well as women were taken care of. So, and post COVID, it took because we have a good infrastructure for maternal health, it took very little time for us to get back to the goal of reducing maternal mortality. But again, I'd like to end by saying it's a care and concern for our mothers that I value as much as maternal mortality going down.
Beautiful.
We'll come to you now just to analyze this a little further, but let's go back to Dr. Pawan for a second. Doctor, can you just tell our audiences, part of this story is the schemes that were introduced over the last few years, and we can see how positive their impact has been. But tell us about behavioral change. How did you encourage women's families to actually bring women into hospitals for these checks? Because that's also significant.
Yeah. So we have to understand that pregnancy is a physiological phenomenon. It's not a disease. So what was the reasons maybe 2 or 3 decades back why the MMR was high? We have to understand that. There are 3 kind of delays were happening at that time. One was delay at the family level. Family was not aware the importance of institutional delivery or getting a delivery at the institution. Second delay was delay in the transport or reaching to the health facility. Third delay was even if you have reached to the health facility was not geared up to take that mother for the normal delivery or cesarean section. So with the progression of time, there were various issues at that time, maybe HR, competency, shortage, equipment, skill set, bed availability, transport problems, roads. So in last 2 to 3 decades, many changes they have happened. First of all is if we go back to 2005 when the JSY scheme was launched, which is called a Janani Suraksha Yojana. It promotes the institutional delivery. It brings a behavior change. You are giving a kind of a cash incentive if you are coming to the health facility for the institutional delivery. It helps in 2 ways. One is a motivation to go to the health facility. Second is the out-of-pocket expenditure which the women or the family is spending by loss of wages. So you are compensating that by giving some kind of a financial incentive, which are different in high-performing state, low-performing state, SC, ST kind of our mothers. So we give access to the incentive in terms of financial. Then in 2011, another scheme came, which is called as a Janani Sishu Suraksha Karyakram, which also eliminates out-of-pocket expenditure. Means if you are going the public health specialty, no spending of money from your pocket. All services like blood transfusion, drugs, diagnostics, food, referral, transport, everything is free of cost for 3 days for a normal delivery and for 7 days for an institutional delivery. As long as you are in the hospital, you need not to spend any penny from your pocket. And even if the newborn is born and till 1 year of age, if any kind of illness, sickness happens to the newborn, that is taken care of by the government in JSSK scheme. Third important is improving access basically, which also brings in a behavioral change. Access means you should have a dedicated delivery points in the country. You should have a 24/7 primary healthcare centers. You should have a FRUs, the first referral units. We have a MCH wings, the maternal child health wings. We have a obstetrical high dependency units or ICU, the referral transport, the village and health nutrition days, which are conducted within the vicinity of the village or within the vicinity of the people where they are staying. We have a ANM, we have ASHAs, they are conducting that. Then we have a birth waiting homes. You have hilly area, tribal area. You can't travel at the time of delivery. So you come 7 or 10 days before the delivery, you stay near to the health facility. So this is how the behavioral changes has been brought into the system so that people come forward for the institutional delivery. They feel the importance of getting an institutional delivery.
Yeah, you touched upon a very important subject of behavioral change, and I want sort of Poonam to come in on that one, because anything that women want to fight in this country, it can't just be fought with infrastructure and intent. It has to be fought with society and mindset, which is what brings me to maternal mortality. Conventionally in India, we've put so much of focus on the baby, But postpartum, postnatal, once the baby is born, not so much focus still on the health of the mother. There is such emphasis put by society, family and everybody to ensure that the baby is fine. People forget the trauma the mother has been through. Is that the next leg now of this journey to ensure not just we save mothers, ensure hemorrhages are lesser, we save lives, but also ensure that mentally and physically they are back on track?
So, a large percentage of the maternal deaths actually continue to happen once even the deliveries that happen in facilities, it's when the woman goes home, often in the first week or 2 weeks, that there are a large number of maternal deaths. And I think that's one thing we need to focus on still. And it is not for the government only, it is for the community, the society,
Yes.
the family.
Yeah.
You know, we've come a long way from when women, when women used to die of maternal deaths in the house without even coming to a facility or trying to save a mother by the community or the family. You know, men used to, I've personally seen situations that men say, all right, we'll marry again. But
Yeah.
today it has changed, because I think the interventions, it's very rare that the interventions of the government actually lead to greater importance for a woman's maternal health or a woman's survival. And Dr. Pawan is absolutely right. It is these incentives. It is sad, but we have to give incentives to families and women for them to bring the women, mothers to, or pregnant women to the facility. And Asha's played a big role in convincing also the family. So the introduction of Asha in 2005 was a very welcome step, because she's the one who understands the norms and issues, the attitude, behavior towards women, and yet she understands, since she's been trained by the health system, she understands the importance of saving lives and institution deliveries and care for the mother. The second thing is that women were having so many children. You know, maternal mortality was also partly high because of the number of children women were bearing, given that anemia is very high in India, and the gap was very different. Women would have one child after the other at a very young age. So what has happened is age at marriage has increased, which again is a value of a girl child, sending her to school. But also, please, let's understand that the aspirations of the girls and women have changed. Today, even if women, there's a huge digital divide, women still have access to communication and how the other half lives. So women today wish to have fewer children. They know that the better off communities, people are having fewer children. They wish to send their children to school. They themselves don't wish to marry early. Their aspiration is to marry late, go to be educated, be in the workforce. So all this also helps reducing maternal mortality. And third point that I want to make is, if you see the difference between many states, and much of those states are in South India. If you look at Kerala, for instance, you know, the maternal mortality ratio there is 19, which is close to the developed countries in the world, you know, like Canada's 11. So they invested in women's education.
That's also got to do with their health infrastructure. Kerala, supremely good. Yeah.
You're so right.
Yeah.
It is, but only health infrastructure, when social norms are so rigorous against women, cannot totally be the only factor. Education of women is equally important to save lives, to save mothers. Family access to family planning is equally important for women to be able to space children or have children, how many children they need and want. And
Okay.
that's again a place where the government of India, the health ministry has played a big role. I want to particularly mention something that Dr. Pawan was also involved with in the ministry, Mission Parivar Vikas, where 140, I believe 42 districts, which were high fertility districts, low education, low indicators for women. But government selected these 142 districts, which also had very high maternal mortality, and invested in family planning along with maternal and other health services. But the big focus was on family planning. So it gave women the agency, the facility, everything to practice family planning. And if you look at those 144 districts there, maternal mortality has come down. So maternal mortality is closely linked to family planning, education, well-being of women, and behavior change communication is something that the government has done. But NGOs like us, we had a program called Main Kuch Bhi Kar Sakti Hoon on Doordarshan in collaboration with the ministry. And so, we need to do a lot more. The value of women still needs more investments.
But it's so wonderful to just be able to sit and talk about something where we have made positive movement, and it is undeniable that that movement is positive. Let's just go over to Dr. Pawan for a last question. Dr. Pawan, we were just telling our audiences we're at 97. The goal is to bring us down to 70. That's the next goal. And in previous conversations, you were pointing out that the biggest issue still is getting this care in rural areas, in areas that are cut off. That's still a big challenge. Can you tell us how the government hopes to bridge that gap?
Yeah. So continuity of the previous discussion. Another factor is building a skill, building the augmentation of HR in the country for the maternal healthcare in the country for different states and districts. And then we have different kind of training programs like skill birth attendant program, Dakshta training program for staff nurses, medical officers. Then we have a Daksh training program for ANM, that is auxiliary nurse and midwife, lady health visitors. Then we have a BMOC, the training program. We have a CMOC and LAS, the comprehensive emergency neonatal obstetrical newborn care. Then life-saving anesthetic skills for hard to reach areas where our specialists in anesthesia, they are not able to reach, or a gynecologist, they are not able to reach. So we have a 6 months training program for the medical officer who can deliver the services in the hard to reach area, tribal areas where the people, they are not able to reach. Another important, Sonali just touched upon about the postnatal period. If we see the Lancet, the article, almost 1/3 of the maternal death, they happen in the postnatal period.
Yes.
So we have a strategy to handle that also at the ministry level, we called as a optimization of postnatal care, where we assess if the hospital or institutional delivery has happened, we ask our ASHA to have 6 visits at the home to pick up the warning signals among the newborns and to the mothers. We know once the newborn baby is there at the home in the village, whole family is overwhelmed with the newborn coming in the family, but they forget the mother. So we have envisaged that mother should be looked after by ASHA, picking up the warning signals in a postnatal period during the delivery after 42 days. And same way, we envisage a kind of an incentive also. If there is a healthy outcome among the high-risk pregnancies after 42 days, so we give 250 rupees to the ASHAs. And then we have another important strategy that is we call it a PMSMA, an extended PMSMA, which we envisage that every 9 months, the health facilities, the PHCs or the CHCs or referral units, they should conduct a specialist ANC clinics where the high-risk pregnancies, they can be captured. You know, if during the antenatal period, we capture the high-risk pregnancies as early as possible, we tag them with the next higher facility to get a delivery done there.
Sure.
So we have a line listing through the PMSMA scheme where each mother with a name and a mobile number is tagged with the next higher facility so that those 9 months she can taken care of. So we have a healthy outcome at the end of 9
track,
months.
capture, incentivize, and also give them agency. I think that in a way that circles up and sums up what is really required, not just for, maternal care, but for so many other things in the country. I have to thank you both for joining us. This was really, really refreshing, and good job, guys. Thank you so much for doing what you guys are doing, and so many others. A special shout out to all the ASHA workers. Really, they are the backbone of this movement, and we really need to acknowledge it at every step of the way. We leave it there for the moment. Thank you so much.